Dr. Klinsky, let me ask you on your side as a, kind of a frontline clinician in this area, as an ER doctor, again, I don't, type in, okay, let's give a patient cisplatin.
Yeah.
That's not like an order that I put in. So how long have you been seeing shortages like this that affect your patients?
So I would say around April, and again, talking about this particular shortage with carboplatin and cisplatin, I think around April we started hearing about it, but it was one of those things, I'll be honest, that you're like, oh, this can't possibly happen. This is happening somewhere else. This isn't affecting us. And then, there was one, I think NBC ran an article on it, and then kind of for a month, nothing happened. And then all of a sudden, I would say May really kind of exploded in the sense that majority of cancer centers were either experiencing complete, absence of drug or shortage of drug. They weren't able to procure it from their suppliers. And that quickly made its way to the patients, patients not being able to get the drug or, having to sit in front of a patient and say, I have a treatment for you. I don't know if you'll get it. I don't know when you'll get it. I don't know if the dose I can give you. And imagine, you're already facing this life-changing diagnosis, but there are drugs, you just don't know when you'll get them. And I think that we don't talk enough about that emotional toll that takes on patients, because the uncertainty that everyone was facing was really, really quite tragic. And
when you have that conversation with a patient, I guess it depends on the kind of cancer, doesn't it? Because there are certain oncologic conditions where, we're so fortunate that we have many, many regimens, and maybe this one is a tiny bit better than that one, and you're sort of scraping out, on your Kaplan-Meier curves, your survival curves, a couple of months here. Like, are you able to reassure your patients, or it really depends on the kind of cancer that we're talking about?
So really depends on the kind of cancer, and I will say the Society for Gynecologic Oncology really led the way with this, because unlike in other cancers where you can substitute, in gynecologic cancers it's really hard. You need the platinum drugs. So they led the way, and then ASCO, the American Society of Clinical Oncology, followed and really came up with guidelines for clinicians about when you can substitute, what you could substitute. Can we spread out the dosing? So instead of every 3 weeks, can we give it every 4 weeks to make the drug last longer? Can you reduce the dose? I mean, conversations that, again, how are we here in 2023 and having some of these discussions? But that's kind of what happened. And the challenge really was, do we have data to substitute? Will you sacrifice the efficacy if you switch from one drug to another? And then as a result, if now everyone's shifting to this drug, are we, do we have supply for the other drug? So I think it really, it was very difficult discussions. And again, for some disease types, we were able to make that switch, but not for all.
Okay, and I want to jump over in just a second to some of the policy side, but let me stick with you for one moment, just to pursue that point a little further. As I study outcomes mostly with COVID, but lots of other things too. But like when you're making these switches, I know that in pediatric oncology, for example, they're always tweaking and testing and saying, oh look, let's compare A to B and see how they do. As this is happening, is this just too chaotic for anyone to stop and say, well, actually, this is a little bit of an unfortunate opportunity to see, like, well, are these biosimilars actually behaving decently comparably, or is it just like too random for anything to be learned from this?
Yeah, I mean, I think that it would have been great to be able to study, but you know what, it was too erratic because everyone was at different points in their treatment cycle. Some people had gotten 5 cycles and they had 1 more left. Other people were just starting out. And some of those patients we had to pivot and not do chemotherapy first, for example, and do surgery first where we normally wouldn't. So the circumstances and the situations were each too different to actually look at this in a cohesive way. I do think that, fortunately, people moved fairly quickly to try to get drug and try to increase supply. So, it was kind of, we were in this bad point for a couple of weeks, but it, started to recover. But now we're seeing a different shortage of 5-fluorouracil. And so, unless, and I'm curious about from the policy side, but unless we really come up with long-term solutions, the short-term solutions are going to just lead us to another drug shortage in 3 more months with something else. You
mentioned the word allocation, and that sort of that set off a thought that I wanted to talk about on the clinical side. So, Dr. Klinsky, we know that drugs don't reach every community equally, right? There's a haves and the have-nots and the sort of in between. From the standpoint of oncology, do we sense that when shortages happen, there's a disparity in terms of who's affected?
Absolutely. I mean, I think we have to keep in mind that the majority of patients are still treated in the community setting. Now, for this particular shortage, NCCN, the National Comprehensive Cancer Network, they did a study of multiple NCCN sites, and they found that about, I think it was about 93% were affected by the shortage in some way. But what we don't have information, again, is in terms of like exactly which settings, were more affected than others. But understandably, patients are not, if they're treated in a community site that maybe is not a big center, that's a small site that purchases a very small amount, didn't kind of stockpile, those people are going to be predominantly affected. And very often they cannot travel to a bigger site that has more resources. If they are in a setting where this is the only site, they're limited by socioeconomic disparities. And so absolutely this heightens the already ongoing, disparities that we see in cancer treatment. Absolutely.
And in terms of how that plays out for your patient population or your colleagues, does this lead to your job being almost like a lot of case management in a sense that the medicine, the drugs, but what you need to figure out is who has what and who can go where? Is that really where a lot of resources of your time get spent, or you're in your office?
I mean, that's part of it. I think the challenge too is that, everyone, a couple of months ago, no one knew when more drug would arrive. So a lot of places were sharing with each other, but they were also hesitant about taking on new patients, right? Because if we can't even provide for our existing patients, what's that going to look like? But I think the other piece that really is challenging is if you do have a limited supply, who do you prioritize it to? And, this kind of was something we saw in COVID also in terms of access to care when the pandemic was at its height. And same thing now, do you give it to the person that is going to be cured, hopefully, with this, or someone who needs it for a palliative reason? But how do you make that distinction? And I think those are really challenging questions and really hard decisions for physicians to have to make.
And what do you tell a friend or not a patient, because the patient's coming to you and you're going to treat them. Mm-hmm. But if someone says, look, I got a biopsy and they're sending me to, this oncology center or that one, would you tell them to sort of like look into this? Like, you don't want to go and go down a pathway with a wonderful practice who actually can't treat you, when across the street, for reasons that, we just discussed a minute ago, some negotiation or someone got in ahead of a stampede and a panic and they have the drug. Like, would you advise patients who are looking at this landscape to behave any differently than they would have in another environment?
Absolutely. I mean, I'm a firm believer that patients have to be their best advocate, and you have to be your own advocate. And so I think it's a very appropriate question to say when you're meeting a practice and, you say, I know that my regimen is recommended to, let's say, have carboplatin, for example. Can you talk about where your institution or cancer center or hospital is with regards to these shortages? I think that those are very valid questions. And, part of the things we always say, what should you ask your oncologist? And I think in this space and time that we're in, I think that should be part of the list, because again, like you said, you don't want to all be set up for treatment to find out, well, they don't actually have the drug. I think the challenge is in patients who are not able to do that, who are not able to go somewhere else. And that's really hard.
Yeah. And it's interesting to me, again, I'm an ER doctor, but I work in a pretty fancy, magnet hospital. So people always come to us for second opinions or for like the magic stuff that like that Dana-Farber might have, as if it's any different. And in some cases, look, we have wonderful experts and we have some experimental treatments that are, unavailable everywhere else. But a lot of times when it's sort of straightforward, I kind of feel like, look, we got a nation of really, really qualified oncologists. You don't need to fly halfway across the country to get first-line treatment, and yet some people actually would do that. They want that name brand. But now it's like, actually, you could argue like, look, the big name brands are probably the ones that have the most purchase power and bargaining power. So all of a sudden, it might matter, right? I mean, that's
yeah. I think we don't know, and it varies. And I mean, some of the biggest cancer centers were actually the ones experiencing some of the bigger shortages, and
really?
And it was very variable throughout the country, but you could see on Twitter people were sharing like who's got the drug, who doesn't have the drug, and so it really was very like surprisingly actually, you know, this hospital had it, this cancer center didn't, vice versa. So I think it's also such a fluctuating you know, state, right? It might not, you might have it tomorrow, you might not have it the next week, which is why I think this was so hard for patients, because there was no guarantee of when it would come back. And I think that really exacerbated all of it as well.